for the first appointment, I think it's a very good idea to bring someone with them, actually. A lot of patients spend a number of years getting to the point of actually being seen for the first time and having the diagnosis explained to them, and it's quite a long consultation. And so I think having someone with you who can take notes and kind of help is very good. In terms of preparation, I think it is. I think they should use the opportunities to maybe come with questions, come prepared. Especially initially during the first few consultations. I think when they're well established and kind of coming for their routine follow-up, I think it's important just for them to have kind of kept an eye over issues over the intervening 6 months, for example, because it can sometimes be easy to forget. So those are the main ways for them to prepare. And I think there's always kind of the fear about or embarrassment about talking about other issues outside of just the physical illness, which patients don't often venture towards, and they share with nurses and kind of the CNSs will actually have a much better grasp on actually the whole picture in terms of work, life, social issues and things like that, which we don't necessarily get during our consultations, and I think those are other things that they should be a bit more free to address.
Well, I think the things that I'm really looking to try and establish are, whether there's any sign that the patient has deteriorated more quickly recently. So, signs that the cancer may be growing more quickly than we expect, weight loss, for instance, increasing pain, increasing change in bowel function, diarrhea. So it's really that kind of sense of how the patient, whether the patient's in a fairly stable condition or whether things are changing, over recent weeks and months. So it's important that that the patients do report even relatively subtle changes in how they've been feeling, and any symptoms that they've developed recently that may be signs that the cancer is starting to behave a bit more aggressively.
We want people who have a neuroendocrine on the whole to be living an independent as normal life as possible. Being able to manage their symptoms independently with as few visits to hospitals and blood tests and everything as necessary, but also but the flip side of that is if you've got an issue and it's long-standing or it's something that's concerned, you need to really inform the team, because sometimes it's so simple to sort out, but the longer you leave it, the more impact it will have on your life, and digestion certainly that sort of thing. And we're using drugs differently now, so we're using somatostatin analogues, the monthly injections, far more frequently than we used to because of the PROMID and clarinet studies, which means that these patients are having more treatments for longer time, so the impact on the side effects aren't fully known yet. So it's important that people don't sit on their problems. Colour, consistency, it's not a very pleasant discussion to have, but it's something that helps to differentiate the causes of all these things. Do you have terrible wind that's quite offensive? These are discussions I have every single day, but I understand it's embarrassing sometimes for the patient. So my role is to broach these things in a tactful and meaningful way. But also I would say to the patients, don't be embarrassed, be honest. We know that things happen and it can be sometimes in embarrassing situations, or they're difficult to deal with, or they've been happening for a long period of time, but mention them, because actually there's things that we can do to help resolve them. Not right then sometimes it's referring to other specialities within the MDT who can offer a different insight.
I think if in individuals who have syndrome, then obviously I think that worsening their symptoms, especially, can be quite a clue. I mean, we often use weight as a very good surrogate marker, and loss of appetite or kind of fatigue and things creeping in. But you can actually often track and see that people start losing weight, sometimes not realising it themselves, and it's only when they're kind of being monitored. You say, your weight lost kind of half a stone or 3 or 4 kilos, and then that can often be a subtle sign. And loss of appetite, again, decrease in activity, it can be quite gradual with these conditions, and it can be over 2 or 3 years that, they may have gone from playing golf twice a week down to, you know, not really feeling like they can do a whole 18, which is, you know, some of our patients say, or swimmers or runners, and they change their lifestyle, they change what they do, but they do it in such a gradual fashion they don't realise that actually things have changed. And they just say they're getting old, but not always aware that it could actually be the disease that's changing in its behaviour.
From a patient point of view, episodes of abdominal pain and diarrhea, especially if they wake up the patient during the night, are definitely alarm symptoms. The patient should not wait for the tumor to cause weight loss, because sometimes it's quite late. So an ongoing abdominal pain, and especially diarrhea, which wake them up during the night, should be symptoms that should send them to the doctor. Again, episodes of abdominal pain associated with bloating, nausea and vomiting. So if a pain is relieved by vomiting, this indicates that there is a blockage. Not complete blockage, sometimes a subacute blockage. And this should send them straight to the A&E, especially if they persist. I have to say, we need to think as plumbers, because if a tube is blocked, you just stop eating, drink fluids, and if still is a problem, you go to the hospital to get a drip for a couple of days for the bowel to rest, and if you are lucky and do not need an operation, things will settle by themselves.
I think the key is, if you're concerned, if you are experiencing symptoms out of the ordinary, then don't hesitate. You know, get in contact with your specialist nurses. If they can answer your queries and it seems to be a relatively straightforward one, fine. If there's any concerns, you can always come back to clinic. I think that's the key. In terms of what symptoms to look out for, I think anything that's just unexplained, anything that's out of the ordinary for you, would be reason to get another opinion, would be reason to be seen again. So the different types of symptoms obviously differ on where the initial tumour is and where you may have spread, but certainly if you're having a new symptom that you haven't felt before, or you're having worsening of your previous symptoms, then that's reason to speak to someone, and usually the specialist nurses can advise whether you need to be seen in clinic soon, whether you can wait to your next appointment, or whether we need to bring your appointment forward.
It can be life-changing, and I don't want to over-egg the pudding, but I've had patients whose lives have been changed by starting the correct medication.
It's very important when you have a combination of knowing your disease is stable, knowing your markers are stable, but still having increasing diarrhea, that then I think as a team with the patient, very much part of that team, start looking at other possible causes. Things like bacterial overgrowth, also about malabsorption diarrhea related to previous surgery you might have had, because of bowel salts malabsorption. And those sort of other causes need to be looked at as well. We certainly have seen a lot of our patients where sometimes there may be an assumption that this is because of the syndrome. So you would add in octreotide injections, there isn't any improvement, and at the same time the patient's obviously losing weight, feeling weaker because of the diarrhea. And I think it's just important to think about the other causes that are common, not to neuroendocrine tumor, but to common to the general population. I think it's really important that those are investigated, because it may be simple treatment, bacterial overgrowth, antibiotics, probiotics. Within a couple of weeks or so, the patient's a lot better, and the reassurance of knowing why, and then future treatment can be, appropriately managed with that. Same with surgery-related. The bowel salt malabsorption diarrhea, they may have had a right hemicolectomy years ago, but there seems to be, they're not on the medication for it for whatever reason, and simply by diagnosing that, again, that's a nuclear medicine investigation we can do to confirm that, and then they start medication called cholestyramine or something equivalent, and again, there can be dramatic improvement in their symptoms fairly quickly, knowing you're treating the right condition.
Fatigue is one of, like you say, it's one of the most commonest symptoms of having a cancer. It's also a very common symptom or side effect more of the treatment that patients are on. Especially neuroendocrine patients are on numerous lines of treatment over a number of years, and recovering from these treatments takes a toll on your energy levels. It's also something that isn't often always highlighted in your clinical reviews because it's very hard to characterise. So it makes it difficult to quantify, and often patients are unable to describe it properly. However, in my experience, the fatigue comes in many forms. It can be people complain of feeling as tired when they wake up as when they go to bed, and it can affect quality of life quite dramatically. As you can imagine, it changes people's ability to perform their normal daily roles within the family, and also socially and work-wise. How to manage fatigue is complicated. So if there is a reversible cause of the fatigue, and that could be something wrong with the blood, low hemoglobin, digestive problems, so you're not digesting your food properly, therefore your energy levels are affected, then these should be addressed, the relevant tests doing, and treatment started and reviewed, and this can take a number of months to resolve sometimes, especially the digestive problems. If it's related to treatment, then we would hope completing treatment, fatigue levels would recover. Having an open and frank discussion with the patient before embarking on treatment to the impact on fatigue and ability to perform your normal daily activity is really important. It's important that they understand that it's related to the treatment, and not all of a sudden everything going wrong, all of a sudden I'm unable to do the things that I want to do. On the other hand, we have those patients who are fatigued due to the condition and due to the nature of their disease. And for those patients, I have long chats about managing expectations, things that they can do for themselves, because it's a loss of identity, a loss of independence, and that is impacting their view on themselves and how they are in the world. And so it's about accepting change, ensuring that they use their energy wisely. I always describe the energy levels as a petrol tank, and not to burn out all your petrol in the morning just getting up and having a shower. Spread the things you need to do over the day, and if you've got things coming up that are important to you, social events, holidays, make sure you manage your energy around them. Little things can make a difference, ensuring you're not going up and down stairs unnecessarily, making sure that if you get out short of breath going up the stairs that you rest, and don't see that as something that's negative, but it is a way of you managing your symptoms independently. Things like good, well-balanced diet, good rest, excellent symptom control is also really important, and these patients, like you've discussed and probably numerous times during these little films, is these patients are dealing with their condition and their symptoms for years and become very acceptant of it. So they go, well, I'm supposed to feel like this, I've got a neuroendocrine tumour, and actually no, there's lots of things we can do, improve symptom control, pain relief, all of this will help to improve your fatigue. But mainly it's about trying to empower the people to accept changes in themselves, which is very, very difficult. But having frank discussions in the clinical environment and having the support of people like yourselves and able to ask advice is really important for people to be self-managing this type of could be long-term symptom.
Good nutrition can help with fatigue to some extent, so it involves keeping your blood sugar level stable, and that means having foods with a low glycemic index, so that's the rate that a starch or a starchy carbohydrate will break down into the blood. So we're keeping the glucose level stable, so you don't have any low troughs and high peaks, you're just a constant energy supply, and that helps with mood, and it helps with the energy going to your muscles as well, but you also need to combine that with some exercise. And although exercise is not the first thing that you want to do when you're tired, it will help in the long term, day to day.
Well, fatigue is a quite common symptom of cancers in general, especially if they have spread. However, we should exclude simple causes like, for example, anemia, iron deficiency anemia. So many of those patients, because the tumor infiltrates the gut, quite often are losing small amount of blood slowly, and this blood cannot be seen in the patient's stools. So they should be checked for anemia, iron deficiency. Also, for example, patients who have diarrhea, they may have low potassium, low magnesium, and these are things that we can replace and make the patient better.
So the way we sort of talk about fatigue, sort of in the clinic setting, if you like, with patients, is we try and sort of describe it in such a way to show the levels of intensity often. So if you just say, oh, you'll feel tired, we all feel tired. You have a rest, you wake up, you feel better. Fatigue is different. Fatigue, when you're looking at describing it, and for patients to help guide us about the grading, if you like, intensity, is so if you rest, when you wake up, you're still tired. And it's about, and you go to bed at night, you wake up, you're tired already. And then that level just increases throughout the day. And it's that sort of thing. So starting from, no, I'm fine, I rest, I feel fine, to, oh yes, I do wake up a little bit tired, but I can still get on and do things, and then if I rest again, my energy levels improve and I can carry on. Then the next level is, I wake up tired, I still do things, but when I do them, I'm shattered, I stop, I rest, but my energy levels do not recuperate. So that's really how we sort of help gauge levels of fatigue for patients, particularly when you're looking at treatment impact. So if you're seeing those levels increase, that is often where we're looking at, okay, should we be dose reducing, or are we doing the right treatment for this patient, because actually we're making them feel worse, not better, for most of the day, especially if they've got that type of fatigue where they're not recovering and they're just feeling so flattened and so exhausted all day and all night. And obviously that's really not a very pleasant experience at all for them. And that means as a healthcare professional, we have to have a discussion with the patient, are we doing the right treatment for you? Fatigue is a massive, massive issue throughout all cancers. I don't think it's anything specific to neuroendocrine tumours. It's been it's massively investigated, and there's huge amounts of research on fatigue, whether it's about measuring it and that sort of thing, but actually the answers of what to do is really still not been answered. There is no quick fix, absolutely not. And certainly when discussing things with patients, the strategies that we talk about is about managing it. So we can't take it away, because as you've alluded to, and as patients describe, even with stable disease and everything behaving itself, the fatigue is there. So it's about the body having to live with the condition seems to take this level of energy away from them. So we want people to live as normal a life as possible, and their normal life may become a new normal life where they've had to adapt things, and it's about a very personal thing for patients about what they can adapt and what they want to do to manage it. Things like gentle exercise has been shown to be helpful, and by that I'm talking about going outside for a walk every day, making sure you get out of the house, get some, if we can, and we live in the UK, you can get sun on your face. That's a massively positive, and that also helps lift the mood, because fatigue drags the mood down with it, feeling exhausted all the time. So it's gentle exercise every day, it's eating and drinking well, it's making sure your vitamin levels have been checked. Are there any other causes for adding to your fatigue? So iron levels, thyroid levels, those sorts of things, vitamin D, those sorts of things that need to be looked at really, alongside everything. We also talk about pacing your day. So you would have strategies, so you wouldn't plan too much in the same day. Have rest periods where, even if it's resting is going and having a cup of coffee with your friends rather than going to bed. It will depend on your level of fatigue, and a lot of patients do talk about building those strategies in to help manage the fatigue. But there is no quick fix, unfortunately. There is no easy way for it to go. So a lot of it is about adaptation.
In terms of altered appetite, usually the treatments are the main cause of the altered appetite. So things like radionuclide therapy, the lutetium and yttrium treatments, very commonly chemotherapy if you've happened to have that. And there are other treatments as well. Things like everolimus and sunitinib commonly cause appetite problems and some weight loss associated with that. In terms of changing taste, there are things like possibly zinc deficiency which can affect the taste buds, and that's something that you could get checked out for if you're at risk of zinc deficiency. Luckily, we do have taste buds that renew themselves on our tongue, so every few weeks we do get a new round of taste buds, and over time they should replace themselves, although sometimes people do go on for a year or two with altered taste. But to get that taste back, obviously if there is a deficiency like zinc, you would need to take a zinc supplement through your GP. And then try out different flavours. So very strong flavours are the obvious choice if you've lost your taste, and having, you know, something that's really going to get to your taste buds rather than mild foods. If you've got an altered taste, and that's very common with things like chemotherapy, where your favourite food might not be your favourite food, it might be your worst food, and the smell associated with that is also quite disgusting for people. So you would just then again play around with what smells and what tastes you can tolerate without feeling a bit nauseous with it. Sometimes that's ginger, sometimes that's lemon or mint, something refreshing. The smell and the taste of meat is often not tolerated, and actually if you cool down food and not have it hot like you would have, say, lasagna, you might try it a bit colder. That might be better tolerated too. If you have all of those calories and it's coming straight back out, most frequently with NET patients in diarrhea or steatorrhea, which is the fat version of diarrhea, then you know, you're not going to gain any weight and you're not going to absorb the nutrients as well. Most commonly, fat-soluble vitamins are depleted in things like the steatorrhea, and there's also problems with things like bacterial overgrowth, so that can cause lots more energy loss through the bowel, through loose stools. So what you would need to do is nip those energy losses in the bud, and you would need to try an enzyme if that's something that the nurse team and the doctors feel that you might benefit from. If it's it depends on the course. If the cause is your pancreatic insufficiency caused by treatment or any surgery, then you would try the enzyme. If it's something further down in the ileum or very low down in the small bowel, then you would try a bile salt binder, and that binds up the stools so they're not loose anymore. And with that, you would then increase your energy and protein intake, very important, just to increase and not necessarily follow a traditional healthy diet, but get more calories in. And if that means having more cream cake with extra cream or some maybe cream cheese, or you know, anything that you tolerate and you actually have a benefit from, then you need to have that. And if that doesn't help, then we would try a supplement milkshake or a supplement juice or a supplement powder as well to add in the gap of the energy requirements.
There's different types of malabsorption. For the pancreatic one, which is the one that we talk about being associated with either pancreatic surgery or somatostatin analogues, medication related, it's a fecal elastase test. It's a stool specimen that can get sent off, and that will be tested. And if the levels are abnormal, then that is a confirmation of the diagnosis. So you can absolutely test for that. As I say, the other type of malabsorption is bile salt malabsorption, and that is called a CCAT test, which is a nuclear medicine test that, again, if that shows abnormal results, you can direct treatment absolutely to the right cause. And it's very important alongside that to be remembering about the fat-soluble vitamins that are going to be malabsorbed throughout that type of diarrhea. So along all these tests, they should be doing the vitamins, and we standard practice is certainly improving now, where whenever you're having your tumour markers done, you're including the fat-soluble vitamin blood test in there, so that makes sure people are on the vitamin supplements they need to be for these sort of more chronic conditions. So bacterial overgrowth is a condition where naturally in our small bowel and small intestine we do have bacteria, and that helps the body work and function. Unfortunately, due to medication, surgery, those sort of factors, the bacteria can move and you can end up with the wrong type of bacteria in the wrong area. And that affects the body's then ability to absorb food and nutrition. So the best way of testing that, well, the only way of testing it is a breath test, and that could be a hydrogen or methane breath test. And the majority of hospitals will be able to do those investigations for patients. If that shows abnormal results, then the treatment is antibiotics to clear the wrong bacteria away, to let the normal bacteria flourish again, and that helps revert your body back to more normal bowel motions. And so the treatment, although some people do get diarrhea with antibiotics, so again that needs to be looked at for the patient point of view, and if they do give you an antibiotic that doesn't suit you, the diarrhea will get worse. So it's about managing that sort of thing. But once you've had the antibiotics, within a week the diarrhea can dramatically improve if it's down to bacterial overgrowth, which is why it's so important to know the cause and then make sure it's the right treatment that's being given. The fat-soluble vitamin testing should be done at baseline, so at diagnosis, if you like, wherever the specialist centre, or start of a new treatment. And then we're doing it 6 monthly. You could do it more often than that, obviously, if there's change of symptoms occur. But that's really what we're looking at. If you do it too close together, so if you start the vitamins, you would need to give it several months before you recheck to see an improvement. It's not an immediate impact that you see on the blood test, so people do need to be on the supplements for quite a long period of time to get the benefits.
We will one day get to the stage of recommending some guidelines. At the moment we don't have guidelines for NET patients to recommend which vitamins and when to test, because each vitamin will deplete at a different rate, and it will be different for different types of NET as well. But we do our best to try and go by the studies that have come out, and they involve the fat-soluble vitamins, showing that people that are on the long-acting injections, usually every 4 weeks, after 18 months, people are at risk of fat-soluble vitamin deficiency. And we know from other things like the surgery of the terminal ileum, so very low down in the bowel, or if you just have an ileal net down that way, that can affect vitamin B12 absorption, as can a gastrectomy, so resection of the stomach, or maybe you've had a Whipple's operation as well, which includes part of that. So you are at increased risk of B12 deficiency in that case. The other things, if you have very frequent loose stools, and you have done for a long time, you will be at risk of all the other micronutrients, all the minerals, selenium and the zincs, and possibly iron is a common one too.
Many things that can affect people's psychological and emotional well-being. Having a diagnosis of any cancer causes an emotional adjustment. So if you've got any pre-existing or history of emotional issues, that's something that's going to trigger. And it might not be something that triggers straight away. Often lots of things are happening to the patient all at once, and then there's a time once all of the investigations and treatment pathways have been decided on, say, that people are then allowed the time to think about the implications emotionally of their diagnosis. And in regards to treatment, there's lots of drugs that we use that could affect people's chemical balances. We use steroids in a lot of treatment regimes, which can affect people's mood, and quite dramatically so. but it's about being honest and talking about those tricky subjects. Asking someone if they're depressed can sometimes feel that you're going to open a can of worms, but actually sometimes it's the question that, you know, leads to the most enlightening discussion. And I always say often in these cases the emotional symptoms can be more impacting on quality of life than the physical symptoms, and they are difficult to talk about. But the more empowered your patient is, and the more educated your teams are, you know, your medical teams, the easier this is. And it's also about not referring people to the relevant sources. And often just having a conversation is enough for people, being recognised that this is an impacting condition. And then on the flip side, there's patients who don't have any thing they want to discuss with you about such things, but you need to be able to identify and honestly discuss with all patients.
With carcinoid syndrome, primarily, there is you can get manifestations of anxiety and mood disturbances, and usually these can be quite subtle, sometimes they can be more overt. I think we've had a number of patients who we used to look after together who had very marked anxiety, which was very much improved on analogues, and other people who've actually had mental health disorders previously diagnosed that actually, when they established an analogue therapy, seem to improve quite markedly. So I think there's definitely a reason for monitoring that, because I think it is a symptom of carcinoid syndrome, but not very well understood, and also it's hard to tease out from someone's underlying personality what's disease and what's actually kind of such organic disorders. So that's part of the reason we ask about it. And the second part is obviously living with cancer does carry its own kind of emotional and psychological strain. And so by doing the quality of life, you may do very well at responding to people's physical disease, but maybe not their psychological disease, and that's actually a very big aspect, especially when dealing with a condition that can people live with for decades in some cases. So I think that's the other reason for monitoring it. I think it adds a new dimension onto the consultation, because so the IMPARTS is basically doing EQ5D and the Net Quality of Life questionnaire, which patients do. I think one, it gives them an idea of how things are going sequentially, but sometimes it's hard to remember how sick or ill you're feeling necessarily, or whether you've actually had a good response. It kind of works quite well that way. But it's also quite helpful for flagging up to us aspects about depression and anxiety, which again wouldn't normally necessarily be entertained in a consultation, but it does add that new kind of aspect to their care, and also engaging primary care services if we do identify individuals who've got clear issues with depression and significant anxiety.
Are there any additional cancers that may develop in patients with neuroendocrine tumours? The first thing to comment on is that these may sometimes be part of familial or hereditary syndromes. So this, I think, will be covered by another expert. There is no doubt that there is an increased association of colonic tumours, some of which may be simple polyps, but there may also be fully invasive bowel cancers. They undoubtedly do occur more frequently in association. Sometimes when a patient has a small bowel neuroendocrine tumor resected, you can see coincidental colonic carcinomas, that's bowel cancers, in the specimen, so it may actually arise simultaneously. But there is an increased association of either prior colonic tumours or developing bowel tumours later, and therefore some experts do believe that some kind of screening might be necessary in these patients. The screening could take the form of colonoscopy every 3 years. Apart from that, I'm not aware of any other definite associations. I think this is something we're going to learn more about over the next 3 to 5 years, and it wouldn't surprise me if you were to sort of fast forward 5 years and rerun the question, that we would give a rather more exhaustive and fuller answer, because we'll identify other tumours.